Right now, there are, millions of people taking a daily medication that actually requires their own gut bacteria to literally digest the pill before it can even start working.
Yeah, it's pretty wild.
But for decades, we've just thought of this entire class of drugs as, crude, embarrassing plumbing tools. We really only think about laxatives when we're in a state of absolute uncomfortable desperation and we just want the problem solved.
Which is really a shame, honestly, because the pharmacology behind how we get our bodies moving again is, well, it's a masterclass in human physiology.
Right.
We're looking at a system that relies on precise chemical signaling, fluid dynamics, complex nerve stimulation. I mean, it is vastly more intricate than the typical bathroom humor usually associated with it.
Welcome to this deep dive. Today we've got a massive stack of pharmacological sources, historical texts, and clinical guidelines. And our mission for you today is to uncover the brilliant, surprising, and sometimes highly controversial mechanics of relieving constipation.
Yeah, it's a big topic.
It is. Okay, let's unpack this because we are going way beyond the basics here to look at the literal levers of the digestive system.
And just to set the stage, the scope of what we're analyzing today covers an enormous timeline. I mean, we are tracing this from ancient herbal remedies that have been used for millennia,
Yeah.
all the way up to cutting-edge receptor antagonists that intervene on a, microscopic cellular level.
So let's actually start with that history. I was reading through the etymology, and the word laxative itself comes from the Latin word laxer, meaning to loosen or to relax.
Right, which makes intuitive sense.
Exactly. But the sources show humans have been obsessing over this for a very, very long time.
Oh, absolutely. If you look at the Ebers Papyrus from Egypt, which dates back to roughly 1550 BCE, they were already recording the use of things like castor oil and senna-like plants for bowel complaints.
And here's where it gets really interesting to me. Ancient physicians were prescribing the exact same plants, like senna, that you can literally go buy at a pharmacy right now, but they were using them under a completely different, frankly misguided theoretical framework, like the Hippocratic and Galenic humoral theory.
Right, the four humors. So the prevailing medical dogma for centuries was that human health was governed by these four vital fluids: blood, yellow bile, black bile, and phlegm.
Just a totally different way of seeing the body.
Exactly. Illness was interpreted as a physical, like hydraulic imbalance of these fluids. So if a patient presented with a fever or even severe melancholy, a physician wouldn't prescribe a laxative to stimulate gut motility. They would prescribe it to forcefully purge the body and drain the excess black bile or yellow bile.
It was essentially medieval fluid management.
Yeah, that's a good way to put it.
They had the right tools, but a completely wild misunderstanding of the biological blueprint. But even jumping to modern pharmacology, the definition of what exactly a laxative is seems to be, well, kind of a moving target. I noticed the texts often struggle to differentiate between a laxative and a cathartic.
Yeah, what's fascinating here is that historically, pharmacology drew a very strict line between the two.
Okay.
A laxative was understood as a mild agent, right? Acting locally in the gut to produce a soft-formed stool. But a cathartic was a completely different beast. It was meant to produce a rapid, violent, watery evacuation.
A full purge.
Right. But today, that boundary is heavily disputed. Standard textbooks and the FDA often treat the terms as interchangeable now, just lumping them into a single over-the-counter drug class.
And the blurring of that line seems directly tied to how advanced these drugs are getting. It's no longer just a choice between a gentle nudge and a violent purge, right?
Exactly. For decades, a laxative was simply a substance that stayed inside the gut lumen, the hollow tube of the intestine, and it either drew water in or irritated the lining.
Pretty basic mechanics.
Very basic. But in the last 30 years, pharmaceutical engineering has given us prosecretory drugs and targeted receptor antagonists.
Which are totally different.
Completely. These molecules don't just passively sit in the gut. They actively bind to specific ion channels, or they block opioid receptors. Because they are highly targeted systemic drugs, it has sparked a genuine definitional debate over whether they technically count as laxatives at all.
Right, since the classification really comes down to how the drug interacts with the anatomy. So let's break down those interactions for a second. When you read through the foundational mechanics of the colon, it's really helpful to picture it like a complex, slightly sluggish plumbing system.
Yeah, that's a great analogy.
To get things moving, the body relies on a few primary first principle mechanisms.
Right. The baseline mechanics rely on three distinct forces: how much bulk is stretching the intestinal walls, how much water is physically present in the system, and how intensely the muscles are contracting.
Okay, so let's look at that first force bulk-forming agents. This is your standard psyllium husk derived from the Plantago ovata seed. In our plumbing analogy, this operates like sending a giant water-absorbent sponge down the pipe.
Yeah, these are essentially soluble fibers. Once ingested, they travel down to the colon intact, and they just begin absorbing surrounding water.
Like a sponge.
Exactly like a sponge. And as they swell, they significantly increase the mass and volume of the stool. And the biological key here is mechanotransduction.
Mechanotransduction.
Yes, so your colonic wall is embedded with stretch receptors. When that swollen fiber physically pushes against the walls, those receptors fire signals to the enteric nervous system, triggering peristalsis.
Which is the wave-like muscle contractions that propel matter forward.
You got it.
What stands out to me is how purely mechanical that process is. There's no active pharmaceutical ingredient being absorbed into your bloodstream. It's just physical tension, which entirely explains the findings in the 2005 American College of Gastroenterology review highlighting psyllium's safety profile.
The lack of systemic absorption is precisely why gastroenterologists consider it a first-line treatment. You aren't altering the body's internal chemistry. You're just providing architectural bulk.
Yeah.
And that makes it uniquely safe for essentially unlimited long-term daily use. And it's notably safe during pregnancy, where systemic drug absorption is obviously a major concern.
Yeah, that makes total sense. But bulk only works if there is enough fluid in the system to actually swell that fiber, right? What happens when the colon is completely dry?
That brings us to the osmotic laxatives.
Right, so if bulk formers are a sponge, osmotics are designed to flood the pipe. But the literature makes it clear they don't all achieve this the same way. The sources feature this head-to-head comparison between PEG 3350, which most people just know as Miralax and Laxatives.
Both of these substances rely on an osmotic gradient. Because they are poorly absorbed by the gut, they just remain in the bowel. Their chemical presence alters the osmotic pressure, forcing water to be drawn from the surrounding intestinal tissue into the stool to balance the concentration.
Okay, so they pull water in.
Right. However, the 2007 Lee Robichaud meta-analysis revealed a massive divergence in the actual patient experience between PEG and lactulose.
And that divergence comes down to how our gut bacteria react to them, doesn't it? Because PEG is essentially ignored by the body.
Exactly. Polyethylene glycol, or PEG, is inert. It is a long-chain polymer that is neither absorbed by the human body nor metabolized by colonic bacteria. It simply pulls water into the lumen and exits.
Clean and simple.
Very. Lactulose, on the other hand, is very different. It's a synthetic disaccharide, which is a type of sugar. It also reaches your colon completely undigested, but your gut microbiome absolutely thrives on it.
Oh, boy. And when billions of bacteria start feasting on a sugar, the byproduct is gas.
A lot of gas. The bacteria rapidly ferment the lactulose into short-chain fatty acids. That metabolic process produces massive amounts of hydrogen and methane gas, resulting in severe bloating, cramping, and flatulence for the patient.
Which sounds miserable if you're already constipated.
It really is. And this physiological reality is exactly why PEG has largely replaced lactulose as the default first-line osmotic recommended by medical societies. You achieve the water-drawing benefit without turning the colon into a fermentation vat.
Now, if you're listening to this and you've ever stood in a pharmacy aisle, you've probably seen another type of osmotic, the magnesium-based ones, like milk of magnesia or magnesium citrate.
Oh, yes.
It's super easy to assume that because magnesium is a natural mineral, it must be universally safe. But the sources highlight a huge warning label here.
They do, and this raises an important question about the assumption of safety with over-the-counter minerals.
Yeah.
Saline osmotics, like magnesium, create an extremely steep, aggressive osmotic gradient, meaning they work very fast.
Right.
But while most of it stays in the gut, the body does absorb a small fraction of that magnesium into the bloodstream.
Okay.
For a person with healthy kidneys, this is irrelevant. The kidneys simply filter the excess out in the urine.
Right.
But for a patient with renal insufficiency, someone whose kidneys are failing or impaired, they physically cannot clear that mineral.
So the magnesium just keeps circulating and building up in the blood. Why is that lethal?
Well, the nephrology literature has documented tragic cases of fatal or near-fatal hypermagnesemia in these patients. Magnesium plays a critical role in nerve and muscle function, especially the heart.
Oh, wow.
Yeah. When levels become toxic, it disrupts the electrical signaling of the myocardium, leading to severe cardiac arrhythmias and even cardiac arrest. It is a very stark reminder that natural does not automatically equate to safe when an organ system is compromised.
That is genuinely terrifying. Okay, so we've looked at adding bulk and we've looked at pulling water through osmosis. But what if the issue isn't the consistency of the stool, but the fact that the colon muscles themselves are just sluggish? You need to actively stimulate the muscle.
Enter the stimulants.
Right, senna and basakadil. These act directly on the enteric nervous system, which is often called the second brain in our gut.
Right. They stimulate the myenteric plexus, which is the nerve network embedded in the intestinal wall, forcing the colon to actively contract while simultaneously promoting some fluid secretion. And the pharmacokinetics here, how the body chemically processes these drugs, is genuinely fascinating.
And this loops perfectly back to what we touched on at the very beginning of the deep dive. If you swallow a senna tablet, the senna itself doesn't actually do anything to your nerves, does it?
No, not at all. Senna is a classic prodrug. When ingested, it travels through the stomach and small intestine in a completely inactive state. It literally requires the bacteria in your colon to break it down and metabolize it into its active compound, which is called rhinanthrone.
Rhinanthrone.
Right. Only that specific bacterial byproduct is capable of stimulating your nerves. Because that microbial digestion takes time, senna has a built-in biological delay of roughly 6 to 12 hours.
Which perfectly explains the standard medical advice to take senna at bedtime. You are literally giving your bacteria the night shift to manufacture the active drug so it's ready by morning.
Exactly. It's a biological timer.
Right.
But bisacadil operates on a different timeline entirely.
Right, because that's synthetic.
Right. Bisacadil is a synthetic molecule developed in 1953 by the German pharmaceutical company Meyer Boehringer. Unlike senna, it does not need bacterial conversion. It stimulates the nerves directly.
Okay.
If taken orally, it still requires 6 to 10 hours just to travel down to the colon. But its synthetic nature allows for a different route of administration, rectally, as a suppository.
Which changes the entire use case because you bypass the transit time completely.
Exactly. The chemical hits the colonic nerves immediately upon dissolution, triggering massive contractions in 15 to 60 minutes. It's the exact same active molecule, but changing the physical delivery method shifts it from a slow, overnight process to an acute, rapid intervention.
Wow. Okay, so those are the blunt instruments, stretching, drowning, or squeezing the gut. Let's look at the new frontier, where pharmacology gets much more precise. Emollients, secretagogues, and lockpickers. Let's start with docusate, a standard stool softener, because the data on this is shocking.
Ah, yes. You're referring to the Cochrane reviews evaluating its long-term efficacy.
Yes. Docusate is classified as an emollient or surfactant. It's supposed to lower the surface tension of the stool, acting almost like dish soap, allowing water and fat to penetrate and soften it. It is prescribed constantly in hospitals, yet the rigorous trial data shows that for chronic constipation, it frequently performs no better than a placebo.
It's true. We see this clearly in modern pharmacological audits. It's a classic case of clinical habit outpacing evidence-based medicine.
Just doctors doing what they've always done?
Pretty much. It functions as a very mild prophylactic, perhaps useful for someone who simply needs to avoid straining after surgery. But physicians have prescribed it for so many decades that it became an entrenched automatic reflex, despite high-quality trials demonstrating it really lacks the power to resolve established constipation.
So if emollients are an evidentiary letdown, the prosecretory agents, the secretagogues, are the opposite. Drugs like lubiprostone, approved in 2006, and linaclotide. These aren't just shifting water around, they're actively hacking the cellular machinery of the gut.
This is where we transition from plumbing to cellular biology. Lubiprostone specifically targets and activates ClC2 chloride channels located on the apical membrane of the intestinal cells.
Okay, so what does that actually do?
By locking onto these channels, it forces the cells to actively pump negatively charged chloride ions into the gut lumen. Water naturally follows that chloride to maintain equilibrium, hydrating the space.
Oh, that's clever.
Right. And linaclotide takes an even more complex signaling path. It activates a receptor that increases the production of an intracellular molecule called cyclic GMP.
Wait, I need to pause here. I understand that raising cyclic GMP drives fluid secretion, but the sources say linaclotide is specifically crucial for patients with IBS-C irritable bowel syndrome with constipation because it reduces visceral pain. How does increasing a random signaling molecule in a cell make my stomach hurt less?
It actually alters the electrical threshold of your nerves. Yeah. In patients with IBS, the pain-sensing nerves in the gut are hypersensitive. They fire off pain signals even during normal digestion. When linaclotide raises cyclic GMP levels inside the intestinal cells, that cyclic GMP is transported out of the cell where it interacts with the nerve endings sitting just below the tissue surface.
Oh, wow.
It effectively stabilizes those nerves, raising the threshold required to trigger a pain signal. It's a dual mechanism drug. It hydrates the gut to fix the constipation while simultaneously turning down the volume on the localized pain receptors.
That is a brilliant piece of engineering. But speaking of brilliant engineering, we have to talk about PAMORAs. This stands for peripherally acting mu-opioid receptor antagonists. This class was designed specifically to combat opioid-induced constipation.
The clinical challenge with opioids is severe. When a patient takes an opioid for severe pain, the drug binds to mu-opioid receptors in the central nervous system to block pain signals.
Right, in the brain.
But the anatomical problem is that the entire gastrointestinal tract is also densely lined with those exact same mu receptors. When the opioid binds there, it inhibits peristalsis, essentially paralyzing the gut. Standard laxatives often fail entirely because they are trying to stimulate a system that is chemically locked down.
Okay, I am genuinely confused by this. If the mu receptors in the gut are physically identical to the mu receptors in the brain, how can a PAMORA drug possibly know to only unlock the gut without also knocking the opioid off the brain receptors and ruining the patient's pain relief?
Right, it seems impossible.
Yeah.
But if we connect this to the bigger picture of neuroanatomy, the secret isn't in the receptor, it's in the barrier.
The blood-brain barrier.
Exactly. The human brain is protected by the blood-brain barrier, a highly selective membrane that keeps toxins out of the central nervous system. A PAMORA, like methylnaltrexone, is structurally similar to standard opioid blockers, but it has been synthesized to have a larger molecular weight and a strong electrical charge.
So it acts like a bouncer at a club. It's too big and too charged to get through the door to the brain.
That is exactly the right analogy. Because of its size and polarity, the blood-brain barrier completely repelled it. It remains trapped in the peripheral nervous system, specifically the gut. It picks the chemical lock on the intestinal mu receptors, unfreezing the colon. But because it physically cannot reach the brain, the patient's central pain relief remains completely intact.
Incredible. With all this advanced science, you would assume gastroenterology has this entirely figured out. But the history of laxatives is riddled with stubborn medical myths, regulatory reversals, and dangerous misuses.
Let's look at the cathartic colon myth.
Yeah, this was a massive, enduring controversy that dictated medical practice for decades. Mid-century medical textbooks adamantly warned that chronic use of stimulant laxatives like senna or bisacodil would permanently destroy the myenteric plexus.
Making the colon lazy.
Right. The prevailing fear was that your colon would become lazy, structurally dilated, and entirely incapable of functioning without the drug.
It made entire generations of doctors and patients terrified to use stimulants. If they were so wrong, where did the myth even come from? The literature actually points to a massive failure in identifying confounding variables. When researchers finally conducted rigorous prospective controlled studies in the late 1990s, they couldn't reproduce this nerve damage.
At all.
Not at all. It turned out the original, frightening data was based on radiographic observations of patients who already suffer from severe, underlying slow transit constipation.
Ah, the classic correlation versus causation error. The patients had damaged, malfunctioning colons to begin with, which is exactly why they were taking massive doses of laxatives.
Exactly.
The laxatives didn't cause the damage. The underlying disease caused both the damage and the laxative use.
Precisely. And the field of gastroenterology has substantially walked back this warning. Now, to be thorough, there is one verified physical side effect of chronic senna use called melanosis coli. This presents as a striking brown-black pigmentation covering the wall of the colon.
See, if I'm a patient and a doctor tells me my colon has turned black, I'm panicking. The sources say it's caused by apoptotic cellular debris accumulating in macrophages. What does that actually mean in plain English?
Well, think of macrophages as the immune system's cellular trash collectors.
Okay.
Apoptosis is just normal, programmed cell death. Senna slightly increases the turnover rate of the cells lining the gut. When those cells die, the macrophages come in to consume and clear out the debris. As they gorge on this cellular waste, they accumulate a dark pigment.
So it's just full trash bags.
Essentially. It looks alarming on a colonoscopy, but modern pathology confirms it is completely benign. It is a harmless cosmetic marker that the cleanup crew has been busy, not a precursor to tissue damage or cancer.
Speaking of cancer risks, that brings us to one of the most famous failures in pharmacology, the NCLEX ban, specifically regarding its original active ingredient, phenolphthalein.
The history of phenolphthalein is a striking cautionary tale regarding regulatory evolution. Phenolphthalein-based laxatives were undisputed blockbuster drugs for almost a century, utilized by hundreds of millions of people globally. Yet in 1999, the FDA effectively banned the ingredient from the OTC market.
How does a drug stay on the market for a century before someone realizes it's dangerous?
It really comes down to changing scientific standards. When phenolphthalein was introduced in the early 1900s, long-latency animal carcinogenicity trials simply were not required or even technologically feasible in the way they are today.
Right, they just didn't test for it back then.
Exactly. In the late 1990s, the National Toxicology Program finally conducted exhaustive, two-year studies on rodents. The data definitively showed that prolonged exposure caused multiple types of tumor formations. The FDA had to issue a massive regulatory reversal based on modern data applied to an ancient drug.
Now, I want to pivot to a deeply serious misconception with life-threatening consequences: the misuse of laxatives for weight loss, particularly within the context of eating disorders like anorexia and bulimia. The anatomy itself proves why this doesn't work, and I think we need to walk through that sequence.
Please do, because understanding the anatomical sequence is vital to dismantling this dangerous practice.
So, when you consume a meal, the food travels down the esophagus into the stomach for acid breakdown and then enters the small intestine. The small intestine is the engine of absorption.
Right.
It is where your body extracts and absorbs almost all the calories, the fats, and the nutrients into the bloodstream. By the time that residual food waste finally reaches the colon, which is exclusively where laxatives operate, the calories are already gone.
This is the tragic biological reality. Laxatives are pharmacologically incapable of blocking caloric or lipid absorption because they act way too late in the digestive timeline. Any immediate weight a person loses on a scale following laxative abuse is entirely an illusion.
It's just water weight.
Strictly water weight loss through severe dehydration in the colon.
And the danger of that dehydration goes way beyond just being thirsty.
Oh, absolutely. The physiological consequences of chronic purging are catastrophic. You are flushing out massive quantities of essential fluids and vital electrolytes. This inevitably leads to hypokalemia, which is a severe drop in blood potassium levels.
And potassium is what regulates the heart's electrical grid, right?
Yes. The myocardium relies on a precise sodium-potassium pump to maintain its rhythmic contractions. When potassium plummets, that electrical grid destabilizes. This triggers metabolic alkalosis and life-threatening cardiac arrhythmias. It is an incredibly dangerous practice that inflicts a systemic organ strain for zero actual weight loss benefit.
Another pervasive myth that drives a lot of unnecessary anxiety-induced laxative use is this cultural obsession with the daily bowel movement. People are convinced that if they miss a single day, they're clinically sick and need medication.
The medical consensus firmly rejects that. The Rome Fair diagnostic criteria for gastroenterology, which is the global standard, is very clear. A healthy, normal frequency ranges anywhere from 3 times a day to 3 times a week.
That's a huge range.
It is. Clinical constipation is defined by the quality of the symptoms: severe straining, hard stools, a sensation of incomplete evacuation, not simply falling below an arbitrary once-a-day frequency metric.
So what does this all mean? We've talked about ancient humors, cellular doors, and plumbing analogies. Why does understanding this specific pharmacology matter so much on a macro public health level?
It matters fundamentally because constipation is one of the single most common outpatient complaints in global medicine. It heavily impacts pregnant individuals, the elderly, post-surgical patients. Understanding these levers, bulk, osmosis, stimulation, secretion, gives you a predictive understanding of your own physiology and the biochemical tools we rely on to fix it.
It goes way beyond just treating temporary discomfort. Think about the opioid epidemic. You detailed how Pamoras work earlier.
Right. Undertreated opioid-induced constipation is agonizing. The literature shows it is a primary reason why patients will actually abandon necessary prescribed pain management regimens. They simply cannot tolerate the gastrointestinal paralysis. Pamoras aren't just a convenience. They are a vital public health intervention that keeps patients compliant with their pain protocols without suffering debilitating side effects.
And then there is the massive impact on colon cancer screening. Back in the 1980s, a physician named Dr. Michael J. Rex Kinney invented the PEG electrolyte lavage solution, commonly known as Goo-Lightly.
Before PEG-based solutions were developed, the bowel preps required for colonoscopies were often dangerous. They utilize high-sodium formulas that cause massive, sometimes fatal, fluid and electrolyte shifts in vulnerable patients. Dr. Kinney's invention leveraged the inert osmotic power of PEG to create a safe, high-volume flush that cleared the bowel without dehydrating the patient.
And the palatability and safety of that specific prep directly dictates whether people will actually follow through and show up for their colonoscopies. By making the preparation tolerable and safe, osmotic laxatives are literally saving lives on a population level by allowing doctors to catch colorectal cancer early.
The pharmacological refinement of the laxative has genuinely become a linchpin in modern preventative medicine.
All right, let's synthesize this journey before we go. We've looked at the core levers, bulk-forming fibers mechanically stretch the pipe, osmotics like PEG passively drown the pipe, stimulants like senna actively squeeze the pipe, and the new secret to GOGs, hack the cellular doors.
The key takeaways are that natural doesn't inherently mean safe, as we saw with magnesium and impaired kidneys, and that the feared lazy colon is largely a historical myth, which is a realization that relieves unnecessary anxiety for millions of patients.
But I want to leave you with one final mind-bending concept to explore on your own. We talked about how prodrugs, like senna and lactulose, are completely inactive on their own. They absolutely require bacterial digestion in your gut to function.
The role of the microbiome.
Right. This means that your specific gut microbiome, your totally unique, localized internal ecosystem of bacteria, partially dictates whether a specific laxative will work for you, how fast it will work, and exactly what side effects you will experience. In a very real way, you aren't just medicating your own human cells, you are feeding a complex chemical code to your bacteria, and you are relying on them to translate it correctly.
It completely reframes how you view a simple over-the-counter pill. You are engaging in an interspecies pharmacological collaboration.
You really are. Thank you for joining us on this deep dive. Keep questioning the everyday things around you, stay curious, and keep exploring the incredible microscopic machinery of the human body.